lateral chest X-ray. Obviously everything is exactly opposite from on a PA or an AP, in as much as our coronal plane positioning, our coronal plane for a lateral then would be, the coronal plane would be, his foot stuck. Coronal plane will be perpendicular to the image receptor. That didn't really seem to matter. Coronal plane perpendicular to the image receptor. The mid-sagittal plane will be parallel to the image receptor. Central rays should be perpendicular to the coronal plane. So we're going to talk about the things that we're going to look at to determine rotation, how much rotation, according to the textbook, is acceptable, and really more of what you're probably seeing in clinicals. I didn't get a whole lot of lateral chest X-ray images from class, and I think that's because there's been a bit of a shift from the standard routine PA and lateral chest X-ray, just not doing a whole lot of laterals anymore. And we're going to talk about the importance of laterals in certain circumstances. I'm not saying that I either agree or disagree with not shooting as many laterals as what we used to. I will say that I went to a seminar as a continuing education thing, probably 10, 15 maybe years ago, where a radiologist was saying that they quit doing laterals altogether except for in special cases, and that was 15 years ago, and it's just now kind of filtered down to us, and it came to us, I guess, via COVID, really. The radiologist at the time just said laterals are useless. I think that's a bit of an exaggeration. I think the truth lies in between, somewhere between it being necessary and it being useless. I think there are certain circumstances where it can be beneficial. So mid-sagittal plane, mid-coronal plane positioning, make sure the arms are elevated and as high as the patient can get them. Maybe not straight up over the head, but as close as possible. Make sure that if your machine uses one of those hold-on-to bars, you use that. Some of your older machines may actually not have that, but may have a kind of like a pegboard with a pole that you can adjust for the patient's height, because it can make a difference. What we want to see, just like on the PA, is from costophrenic angles at the bottom all the way up to the apex of the lungs. And if the arms aren't up high enough, you can see the soft tissue overlap. It's probably not as potentially misdiagnostic as a skin fold or something like that on a PA or an AP, especially AP, in as much as you're not going to mistake it for a potential pneumothorax, but it still is, is visible, right? And we want it to not be visible, but you can also get the bones over it as well. So make sure you get the arms up as high as the patient can go. That comes with the understanding that some of your patients are not going to be able to. I had a patient one time that was an amputee, and it was above elbow amputee, and you may have noticed that most of the time they don't amputate right at a joint. That is because in the amputation, what they'll do is they'll take a portion of the skin and kind of fold it over, and the skin, you can just feel it on your elbow. There's just not a whole lot there, right? So they want some padding there too. So they usually go above elbow or below elbow, for an arm amputation. And this patient was above the elbow, which she was an older lady, and it completely renders that arm almost useless. In certain circumstances, if the patient has let's say they've lost use of a hand, they'll still try to save the hand, because the hand, even though it doesn't work anymore, still gives you some function. Like, you got your notebook out here, tear a piece of paper out of the notebook and spend the entire day writing notes on a detached piece of paper. And what happens? It moves all over the place, right? So, it sounds kind of cruel, but it's paperweight, right? You can still use that to hold the paper down while you write. So, some of your orthopedic surgeons won't completely amputate if they don't have to, but sometimes it becomes necessary. So this lady had an amputated humerus, distal portion of the humerus, but you know, you can't very well use that to hold paper down whenever you're writing. So you have different types of osteoporosis is what I'm eventually trying to get to. And a couple of things. One is, let's put that on the brakes for just a second, but if you've got a joint that you don't use, eventually it's going to get stiff, right? So this lady could not, bless you, this lady could not lift her arm, so she had, you know, disuse in that shoulder. The shoulder was, you know, she had about this much mobility. So on a lateral chest X-ray, just let her, you know, let it hang. Is that going to be a problem? Well, it's going to be in the image, but going back to the osteoporosis, you have two different types of osteoporosis. One is pathologic. That is your normal osteoporosis where you don't lay down as much calcium as what you used to, usually post-menopause, but it could be, you know, other things as well. And the other is what you call disuse osteoporosis. So anytime that you're upright, you're walking, your bones are being broken down, the calcium's being reabsorbed, and you're rebuilding those bones. So stress causes your bones to be healthy. But if you don't have any stress on a particular bone, then you get what you call a disuse osteoporosis. So then again, back to our lateral chest X-ray on this patient, his arm had not been used in a long time. That particular arm over the you know, the lung field on lateral chest X-ray, you couldn't hardly see it. It was like soft tissue. So soft tissue, you know, still casts an artifact, but it wasn't as bad as what you probably would immediately think it was gonna be. It was mainly gone. So get the arms up, if at all possible. Your central ray, C7, should be T7. If you center at C7, you center a little high, right? So make sure, let me go ahead and change that. Yeah. So if you answer C7 on the test, that's your fault. You got it wrong. So T7, possibly T8. And the reason I throw this in is because I'm going to go ahead and skip down here where we can look at a lateral chest X-ray. You notice that the costophrenic angle on a lateral chest X-ray is much lower than what it is on PA chest X-ray. So on a PA or AP, what you might see is the costophrenic angles, you know, kind of a little bit more of the costophrenic angles, you know, on the lateral side, but not necessarily that on the posterior side. If you've ever shot an upright abdomen and you saw below the diaphragm what looked like lungs, so you got the diaphragm here, but you got this thing, you know, that's lighter than the lungs, but it still looks like lungs. That's because it is. It's posterior costophrenic angle. So if you have a patient, we talked about last week, people with a runner's build, tall, thin, have lungs that go on forever. If you center at T7 on a patient like that, in a lot of cases, you're going to clip that posterior costophrenic angle. So even though the Merrill's, and that's what you got to hang on to, is the Merrill's positioning all the way through the registry, even though the Merrill says T7, you might consider when you go from PA to a lateral to center a little bit lower. Drop your image receptor and your central ray just a little bit to make sure that you don't clip that posterior costophrenic angle. And that's why I say maybe T8. Test purposes, we're at T7, but in a clinical setting, you might consider doing that. Single inspiration for lateral, because you already did the two inspiration, you know, inspiration for PA. You don't need it for the lateral. So what we're going to look for is apex costophrenic angle. We just talked about why that asterisk is there. Anterior posterior surfaces, soft tissue of the humeri need to be out of the way. We're going to evaluate rotation as your coronal versus sagittal plane positioning. As long as your sagittal plane is parallel, coronal plane is perpendicular, you shouldn't have any kind of rotation. Your diaphragm should be superimposed, and we'll talk about the significance of that. And then on our seated laterals, if you have a patient that's brought down to the department and they need an AP and a lateral, you might run into some issues with a patient, if you're doing a lateral stretcher chest, so to speak, whenever you set the patient up. So we'll talk about that, and we'll take a look at what that's going to look like. So your positioning just looks like that. So the purpose for the lateral, again, maybe not everybody needs a lateral, so to shift away from it, I kind of agree with. I'm not really questioning the radiologist and whether or not we should shoot a lateral on every patient, but consider anatomy. All right, so how many lobes do you have in your left lung? 2. How many in your right lung? 3. Right, so you got different lobes, and what the lateral gives us is positional evidence of where the patient's pathology is. So we've got a patient here, it's got goobers all in their lungs. You got probably cancers, but what lobe is that cancer in? What does it look like? Just looking at this one over here, what does that look like?
It's like this on the left, the lower.
Okay, so who says lower lobe? It's left lung, so it's only 2 lobes. Who says lower lobe? Okay, so about a third of the class. Who says upper lobe? Yeah. Fewer people, but still some people. So some disagreements there, right? So what we need to consider then is this. I'm going to skip down, and what we have in the different lobes, if you look, this is from an anterior perspective. We've got upper lobe, middle lobe, and lower lobe, but if you look from a lateral perspective, how high does that lower lobe go? And this is right lung.
Almost all the way up.
Goes almost all the way up. So what about the middle lobe? It goes all the way down, right? And then the upper lobe starts in about the lower third, and it goes all the way to the top. So it makes it a little bit more difficult to determine exactly where the pathology is because the fissures on the individual lungs kind of run at oblique angles. So it gives us some dimensional perspective. So on a lateral, we should be able to see a little bit more closely where that pathology is. So back to this one, we've got this here, and on the lateral, because this is right lung, right? So on the lateral, if it appeared pretty much in the middle of the lung, then it would probably be middle lobe. If it appeared anteriorly, it would probably be upper lobe, and if it appeared more posteriorly, it would be the lower lobe, right? So again, it gives us a little bit better of an idea of where we're looking at specific pathology. So on an x-ray, in this one, go back to full view, on an x-ray on this one, they're pointing out this fracture over here. It kind of looks like an older fracture, but looking at this pathology here, all the way up here, if it's more posterior, what would that indicate? It's in the far upper portion of the lower lobe, right? So again, it kind of gives us a better dimensional perspective of what it is that we're looking at and where a particular pathology is. So do we need a lateral on absolutely every patient? Yeah, probably not, but is it still useful? Yeah, it is. Okay, so somewhere in between, every lateral is useless and every patient needs a lateral. The truth pretty much lies. Okay, so just more of the same stuff. Middle lobe syndrome. Anytime you see syndrome, what that means is basically you've got a collection of symptoms that kind of fit where, like lupus. Lupus is a syndrome type thing, and it seems like there are 100 different potential symptoms in lupus, and it seems like if you have 5, then technically you have lupus. Okay, so middle lobe syndrome just describes a lot of different symptoms that if you have a certain number of them, then they say you have middle lobe syndrome. So on the AP, again, just kind of driving the point home, on that right lung, it looks like that's where the arrow was pointing to. The pathology is in the lower portion of the lung, in the lower lobe. And then if you look at the lateral, then it makes it a little bit more clear. That's probably maybe the lower portion of the middle lobe, right? And this illustrates what I was talking about on that posterior costophrenic angle. You got the obvious diaphragm, costophrenic angle, but you see the lung markings back there. You kind of see those little squiggly lines back there? Yeah. All right. So lateral evaluation, again, we're going to look from the apex to the costophrenic angles. We want no overlap of the soft tissue of the arms and the humerus, if at all possible. We want to see front to back. We don't really want to see rotation. It's tough to get a good lateral chest x-ray with zero rotation, right? So you're going to have some, most likely. And the textbook says a half an inch. Anything above more than a half an inch is really excessive. Half an inch is pretty small, really. So, you know, I'd be a little more liberal with that. And then proper placement and collimation, not replacement, but placement. So we already talked about all this, and we'll take a look at the anterior lung compression. All right, so mid-sagittal plane, perpendicular, mid-coronal plane, rather, perpendicular to the image receptor, parallel to the central ray. We've already gone through all that. So what we're going to look at to determine rotation are going to be the posterior ribs. All right, so what we want is perfect superimposition between the posterior ribs. A little bit of rotation is okay. You don't want a tremendous amount of rotation. The other things that we're going to look at are the hemidiaphragms. This bears a little bit of explanation. All right, so your diaphragms, remember that they're not going to be on the same level, most likely. If you have a patient who has COPD, emphysema, they might be closer to being on the same level, but in healthy lungs, what you're going to have is the left lung is going to be lower than the right, right? Now, they should, on the image, appear to be superimposed. And I can't really demonstrate that with my hands because of the way the projector's coming down from the ceiling. But the right lung should be higher than the left, right? Normal anatomy. But because of the divergence of the central ray coming in and because the right lung is going to be further away from the image receptor, remembering that with any kind of angulation, what's furthest from the image receptor is going to move more, right? So what's closest to the image receptor doesn't move all that much, but what's further away moves quite a bit, right? So since the right lung is further away from the image receptor, the left lung is closer to the image receptor, what that means is that the right diaphragm is going to be projected down onto the left diaphragm, and pretty much on normal anatomy, they're almost going to be perfectly superimposed. Not completely, but almost perfectly superimposed. So we're going to look at that, and we're going to look at why they might not be superimposed here in a minute. So we can also look at the shadow of the heart to determine rotation, and we can also look at the gastric bubble. The gastric bubble is really a good landmark to look for to determine almost everything on a lateral chest x-ray. If you have rotation, if you have tilt, anything like that. So we'll talk about that and take a look at that here in a bit. All right, so in your textbook, it says you can look at the shadow of the heart to determine rotation. Full disclosure, I have a hard time with that. So again, what we're gonna talk mainly about is the gastric bubble, okay? So, rotation, what to look for. First off, look at your PA to rule out scoliosis. We talked about scoliosis last week. Your scoliotic patient with the lateral deviation, you're also going to have some twisting as well. What that's going to translate into on a lateral chest x-ray is rotation always. If you know, now you get your image almost in real time. So you make your exposure for your PA, take a look at that. You know, if your patient just doesn't look quite right, you know, whenever you position, and it's usually her, so I'm going to say her. It's usually scoliosis, usually in females. So you make your exposure and take a look at your image on your PA before you really assess your lateral. And if you got scoliosis present, you're not going to get an unrotated lateral chest X-ray, no matter what you do. Even if you can get a good PA unrotated, you're not going to get an unrotated lateral. So, don't go blasting the patient over and over again to get rid of rotation on the lateral chest X-ray, scoliotic patient. So posterior ribs, you want no more than half an inch, I put that in the quotations because that's what the textbook says. But half an inch is almost no rotation at all. So what we're going to look at is the gastric bubble. So imagine your anatomy again. Here, we'll do this. See if I can wedge this in there. It's apparently a gangrenous stomach. They say that this is an unbreakable skeleton.
About to find out.
Was that?
About to find out.
About to find out, exactly. Well, might not. Nah, it's not gonna fit. All right, well, it'll fit. It just squeezes it out, kind of like a watermelon seed. So, stomach, right? So we got a stomach, and if we have rotation, what you're gonna see is anterior to posterior separation of the diaphragm, domes of the diaphragm, right? So they should be right on top of each other for good lateral. Should look like this. But what you're going to see on any amount of significant rotations, you're going to see anterior to posterior separation of those. Okay, so they're not going to be right on top of each other. So what you're going to look for then is the stomach, and there's always going to be a bubble in the stomach, right? There's always just a little bit of gas in the stomach. So what you're going to look for is that gastric bubble. So if you got a patient that's rotated, then not only are the domes of the diaphragm going to be separated, but you're also going to be able to see which one is anterior and which one's posterior by looking at that bubble in the stomach. So if the gastric bubble moves anterior, right, what that means is that the right lung is posterior and the left lung is anterior. So when you go back in to repeat the exam, you know exactly how the patient was standing, right? And you can make that correction. If the gastric bubble is posterior, that means the left lung is moved posterior, right lung is moved anterior, okay? So most of the time you'll be able to see the gastric bubble, but usually if you can't see it, it's because, and you can detect some rotation, it's usually because the right lung is anterior, left lung is posterior. You've got more soft tissue over it than what you would have if you had rotation in the opposite direction, okay? So look for the gastric bubble. If it's anterior, that means the left lung is anterior. If it's posterior, that means the left lung is posterior. If you don't see it, it's a crapshoot, but chances are it's right lung is going to be anterior, okay? And that gastric bubble is posterior. Okay, so I'm telling you, this is work in progress. Left side was up, that should say right side. Okay, so some of the images from the textbook don't translate very well. I can save them in a couple of different ways, and sometimes they come out little bitty, and by the time I magnify them up, this is what you get. So that's what it's talking about, and the images, the description of the image in the textbook shows the shadow of the heart, how it can project anterior to the sternum, which is legitimate, but my eyes, I just don't see it very well, to be honest with you. So gastric bubble is a whole lot easier for me to detect. So in this case, gastric bubble would be here. In this case, gastric bubble would be further back, if you see it at all. So lateral chest X-ray, they kind of put this in as, you know, the textbook example of a good lateral chest X-ray, and it's a fantastic lateral chest X-ray. But that's more than a half an inch, or that's right at a half an inch rotation. Half an inch is a tiny amount of rotation on a lateral chest X-ray. That's a standard you should shoot for, but I'd probably give it a little bit more latitude than that right there, to be honest with you. So scoliotic patient, that's what you're looking at. You're just not gonna get away from rotation on a patient with scoliosis. All right, so what about this one? What do you see?
Gastric bubble shoots into the bag.
Okay, so gastric
Diaphragm
bubble.
pulse in there.
Yeah, diaphragms are not superimposed. Gastric bubble is posterior, so that would mean which lung is anterior? Right lung is anterior. Very good. Also, what we have is the arms aren't elevated, and we've got some soft tissue overlap. But take a look at this patient, and you know they're pretty kyphotic, right? So it's probably an older patient, maybe as high as they can get it. You can probably get rid of some of this rotation, but they may not be able to get their arms up higher than that. So every potential positioning error comes with the understanding that it's patient determinant, and not to armchair quarterback everything that the some of the images that y'all send. Wasn't there with the patient, so I don't know what the patient's condition was. So I'd probably repeat that. And that patient looks like they're a bit more healthy, still have a bit of rotation. It's a little bit difficult to tell where what is. Don't really see a significant gastric bubble on that one, so I would assume that the right lung is posterior. Right lung is anterior. On that one. Again, what we've got here is a patient they're on telemetry, so again, this may be as good as this patient could do, but we've got not just soft tissue, but we've got bony and superimposition over the upper portion of the lungs. You need to try to get those arms up if the patient can tolerate it. So this is where it gets a little bit, a little bit more difficult. So mid-sagittal plane tilt. You ever had a patient that, select your patient, either had broad hips and narrow shoulders, or broad shoulders and narrow hips, and you told them, I want you to put your side up against this board, and they do one of two things. If it's a guy with, and it's usually men with broad shoulders, narrow hips, they kind of lean into it or lean away from it like so. Or you got a woman with broad hips and narrow shoulders, and they lean into it that way, right? So what that's going to do is it's going to take that superimposition of the two domes of the diaphragm, and instead of separating them anterior to posterior, it's going to separate them superior to inferior. Still, though, what you're going to do is you're going to look at the gastric bubble. So positioning-wise, just have the patient put their, just stand upright, completely upright, and not lean into it. So, and you can avoid most of that. But when you have a patient that leans into it, and sometimes your patients will position themselves after you get done with them, right? So make sure you take a look at your patient before you press the exposure button and see what it's going to look like. So we already talked about this on normal anatomy. They should be superimposed, but sometimes you'll have a patient with not normal anatomy. We'll take a look at that too. So lateral chest X-ray should look like so. Got good superimposition, lateral chest X-ray. Now we've got the anterior to posterior. We've got all that stuff. So if we have to shoot a right and lateral, and I put this with a question mark on it, then we're not going to have that superimposition, right? Because you flip the patient around, now the diaphragm that is naturally lower is going to be further projected inferiorly because of the divergence of the central right? So the reason I put the question mark on this is I've got a lot of questions on this. we're going to look at the gastric bubble. Let's say this patient was properly positioned. They weren't leaning in any way. They're calling this a right lateral. This is straight out of the textbook. They're calling it a right lateral, but you see the separation of the two diaphragms, right? So we've got the right diaphragm, is what they're calling the right diaphragm, and we've got the left diaphragm here. But where's the gastric bubble? It's up, right? So if this is a left diaphragm here, right, following this on up, if that's a left diaphragm and that's a right diaphragm, that would mean that the gastric bubble is either above the diaphragm or the patient's anatomy has a stomach on the wrong side, right? So is it a right lateral? I don't know. It's this image, this said it's right lateral in the textbook, but this image leaves me with more questions than what it does answers. So I just kind of wanted to point that out in case you looked at it in the textbook and kind of went, what? All right. So non-superimposed diaphragms can be for a number of different things, not just tilt. Now look at this guy. So what do you see? Look. Got it. Let's move those up. What do you see?
Tissue and
Flat diaphragm.
What's that?
It's kind of a flat diaphragm.
It's a fairly flat diaphragm. Which one is lowest, though? The right diaphragm. Which one should be lowest? Left. Correct. I didn't want to say right. Correct. The left diaphragm is lowest. So you do a left lateral on the patient, and the highest diaphragm is closest to the image receptor. The right diaphragm is going to be projected further inferiorly. Okay? So again, before you assess the patient to determine if they're tilted, if you see vertical separation of the diaphragms, take a look at your PA. What could cause the left diaphragm to be elevated? We talked about it last week. Two things, really.
edema, or no, emphysema.
Emphysema is going to really extend both of them. They're going to be flat. Okay. Close. Close. Obstruction? Well, really one thing, obstruction. Well, no, two things. Obstruction, it could be because of aspiration, right? Or post-surgery. If there's some sort of irritation of the phrenic nerve that controls that side, you may have a frozen diaphragm. So, look at your PA before you, absolutely assess whether or not the patient's tilted. In this case, this is just patient's anatomy. All right, so in this case, we've got a couple of different things going on. We've got separation, vertical separation of the diaphragm. So back to our example, I can't really do this with that guy without possibly throwing him on the ground. But you've got vertical separation of the diaphragms, right? So where does the gastric bubble go if I'm leaning away from the image receptor? It goes up. If I'm leaning towards the image receptor, it goes exactly opposite. So you got a patient with broad shoulders and narrow hips, then it's probably going to go up. If you got a patient with broad hips and narrow shoulders, it's probably going to go down. So now, what do we see here?
Is that bubbles low?
Bubble is low. We also have telltale indicators of what we got going on. Look at how much soft tissue is on that upper arm. That's a big patient, right? We've got a lot of soft tissue there, so the patient's probably got broader hips, narrower shoulders, probably leaning into the image receptor, and that's going to give us a vertical separation, and our gastric bubble is lower and under the lower diaphragm, right? So leaning towards the image receptor. So what we're going to call that is mid-sagittal plane tilt, all right? So we've got tilt towards the image receptor, tilt away from the image receptor. That's what we're looking at, is tilt towards the image receptor. Also looks like, we've got almost no respiratory effort there. We got no lungs, right? So I don't know if they caught them on expiration or if that's the best that patient can do. We've got a tremendous amount of abdomen. compared to the amount of lung. So a lot of things wrong with that. So on seated lateral chest X-ray, in previous editions of the text, what they called this was foreshortening of the anterior lobe. And that's really, first off, you don't have an anterior lobe. You got, inferior, middle, and superior, or inferior and superior. So let's say you've got to do a lateral chest X-ray on a patient and they're on a stretcher. Some of y'all are plenty young that this wouldn't affect you at all, but how comfortable is it to sit with your hips all the way up against the wall and your feet straight out in front of you? You're gonna find out as you get older, it ain't easy sometimes. All right, so you got a sick patient, you got somebody who is so sick they can't stand up. You're going to do a lateral chest X-ray on the patient, and what you're going to have a tendency to want to do, because it's kind of industry standard, to have the patient upright as much as possible, right? So you take the patient on the stretcher and you pull the patient up to a 90-degree angle, and what happens is that the contents of the abdomen are going to push into that inferior portion of the anterior lung field. It's going to deflate it. Okay, superimpose, deflate, and you're going to have this appearance. It kind of looks like, almost like you got a pleural effusion that's kind of affecting the anterior portion of the lung field. Okay, so if you're doing a lateral chest X-ray on a stretcher on a patient, you've got those great big image receptors now, right? Hopefully you've got one of those 17 by 17s in the wall bucky. If you don't, position might get a little dicier. But instead of having the patient sit all the way up, how you can defeat that is to just have the patient lean back a little bit, just a little bit. I'm not talking, 45 degrees. I'm just talking about relieve that pressure. Have patients, possibly spread their thighs a little bit, because again, the older you get, you kind of add on a little bit. So if their feet are straight out in front of them, then that makes matters worse. The gut, is kind of pushed up by the thighs, and it causes that appearance. So spread the thighs a little bit, lean the patient back just a little bit. Instead of 90 degrees, you may be at a 80-degree angle, something like that, and it prevents that. Okay. So pathologies can also cause some problems. Now we get to our pleural effusion. Evaluate your PA chest. Again, we've got vertical separation, but the vertical separation is caused by this massive pleural effusion over there. You're not going to go back and have the patient positioned in a way that your diaphragm is going to be superimposed. Okay, so we got tilt here, right? We got separation of the diaphragms, and we can tell where the gastric bubble is. The gastric bubble is, up into the lung field, so that would indicate what? Tilt towards, tilt away from. Yeah, tilt away from. So we've also got a little bit of rotation here too. So between those two things, yeah, that's a repeat. So just looking at some of the images that we've that I've collected over the last couple of weeks, what would we say about this one? Looks pretty good. We've got some pretty good rotation going on there, even though we don't really see separation of the diaphragms, anterior posterior separation of the diaphragm so much. The posterior ribs indicate we've got some pretty good rotation. What I would need to see on this to really make any kind of assessment is, what does PA look like? Because if we go back to this one on the scoliotic patient, again, our diaphragms, even though they're not perfectly superimposed, they're not anterior to posterior separated very much, right? So, has this patient got any kind of scoliosis? I don't know. You got any kind of information on the patient? Don't remember? Okay. Yeah, I think Chana was, I think here's were the first images that I got, and that was like 3 weeks ago.
Yeah.
So I certainly would get the arms up a little bit and possibly get rid of some of the abdomen.
I think this was a language barrier.
Oh, yeah?
Yeah, so I was trying to
Yeah.
tell her how to.
That introduces a whole different level of issues. So, is that a repeater? Well, consider all things. I mean, can you see what you need to see? More than repeat, what you need to do is need to learn from what you've done before, right? Can that be improved on? Absolutely, absolutely. So you have this patient again, their lungs aren't that long. You might know if the patient can elevate their arms better, and you might know from the PA whether or not we've got any kind of rotation. So on the repeat, maybe you could, make a better image. So do we repeat that one? I don't know. I don't know the patient's history. I don't know what we're looking for specifically on that one. So can we see what we need to see? And if the answer is yes, then why go back and blast the patient a second time, right? So again, you might check with somebody, depending on the patient's condition, say, do I need to repeat this? Even a radiologist. Sometimes, your radiologist can be your greatest ally, or your ER doc if you're working somewhere where you got a, separate ER department. Can you see what you need to see? You got a tough patient, Can you see what you need to see, or do I need to repeat this? The general rule is if you got to ask, it probably ought to be repeated, but there are times that you need to make that case and say, can you see what you need to see, or do I really need to go wrestle this patient a second time? Wow. That's a barrel chest right there. So what do we got with this guy?
I don't really. I just remember we just couldn't fit him on.
Yeah, that's a big barrel chest. You did the right thing in going back and making a second image to include the anterior portion of the lung. And you also did the right thing in, if you've got a patient like this that you just know that you can't fit on the image receptor, you could go back and you could probably position perfectly this guy 15, 20 times. You're just not going to put him on an image receptor, right? So what's the point? Go back and get what you didn't get before, right? Instead of trying to make something happen that's not going to happen. Alternatively, the only thing that you could have done with this is maybe back the SID up another, 20, 50 feet to try to minimize the magnification. You're just not going to fit him on an image receptor. If you'd have had a 17 by 17, maybe, but there was quite a bit of rotation on that one, which you did improve for the repeat, and that's good. So we're going to take a look at some other ones that y'all submitted here in a bit as they become appropriate. I think the rest were abdomen. So with abdomen, mark placement, just out of the anatomy of interest. Some people like to put it in the hip. I like to put it in the hip as opposed to, some people will put it on the upper portion. I'll get it in the diaphragm that way, maybe. So contrast and density, things that we're going to look for is psoas muscles, the liver, if you can see the liver, gas patterns, bony structures. Make sure, just like on a chest x-ray, that we're looking out for the things that would show up. Zippers. A patient comes in a jogging suit, you're going to have a tendency to say, well, the zipper is plastic. Yeah, but the metal, the toggle, is going to be metal. So those got to come off. Snaps, bras when the patient's upright, or decubitus, KVP. Again, I think that we're going to see an increase in KVP over time because our KVP just doesn't affect our contrast the way it used to. So grid use, remember our rules for grid use, and if the standards in your hospital are to use virtual grid, then that's fine. That's all well and good. I don't think they're as efficient yet as what a physical grid is, but they're better than nothing. So is there a time when it's grid use is optional? I'll just leave it the word I used up there. What's that?
You're asking if there's a tone?
Yeah.
Resolving it?
The person's really small.
Okay, the patient's really small. Let's say pediatric patient. You know, we get locked into the idea that on every KUB we have to use grid, right? Because the soft tissue is primarily soft tissue. Pediatric patients, what are your rules for grid use?
70 kg.
70 kVp and up, or 10 centimeters, right? So you got a pediatric patient that is only that thick. 10 centimeters is what, 4 inches? And you got a patient that's 3 inches thick. Do you need a grid? No. Neonates? You're never going to need a grid on a neonate, right? So absolutely. But what about adults? Let's say you find yourself in a hospital that doesn't have a virtual grid. You're doing a portable. You're up on the floor. They just dropped a feeding tube into the patient, and they want an x-ray right now. Are you going to shag it down to the department, grab a grid, come back up and shoot it? You're looking for something very specific, right? Specifically, what is the danger with a feeding tube?
It's going down.
Right, it's going in the lungs. Do you need a grid for lungs? No, you don't. So, could you just shoot it? Take a look at where it is. Is it below the diaphragm? Maybe going into the small intestine, depending on type of feeding tube. You can see all that without a grid unless the patient is enormous, right? So there are times when it's optional. I wouldn't, average size person, I wouldn't go down to the department to grab a grid in that situation. So photocells, it's photocell orientation is going to be really dependent on your equipment. Respiration, I didn't put really any instructions on this because that's also a shift that we've seen locally. Merrill's is always going to say on expiration. And the reason for that is because respiration, what you get as you inhale is the diaphragm drops. That pushes the contents of the abdomen out anteriorly, right? Which increases the thickness of the abdomen, which is primarily water, creates a lot of scatter radiation, complicates the issue. The complication historically has been that's going to decrease contrast, right? But what controls your contrast now? Lookup table, your computer algorithm. I hate to say that contrast isn't an issue anymore because it is. You still have to have contrast, but how you get to that contrast is completely different, and that phase of respiration probably is not as important as what it used to be, right? So a lot of your radiologists are saying, I want you to shoot on inspiration, and that's fine because that's, they're the ones that have to pay the malpractice suit, right? If that's their protocol, then that's what you give them. Just know that every time I ask you, unless there's something special, it's going to be expiration for abdomen all the way through the registry. So respiration is going to be dependent on the radiologist. And then you got to assess for motion. Remember, we've got 2 different types of motion. If your exposure time is long enough, you may introduce some 2 types of motion.
Involuntary.
Involuntary, thank you. I couldn't come up with a word. Involuntary motion, some bowel motion. So KUB, coronal plane should be parallel to the image receptor, perpendicular to the central ray. Sagittal plane should be perpendicular to the image receptors, parallel to the central ray. We're going to look at the pelvis, and the ASIS should be equidistant from the image receptor. Arms slightly abducted, and if you're shooting a KUB, get the arms out from underneath the covers. Anybody seen this little situation going on? You got the little old lady's cold, right? So you put a nice warm blanket on her straight out of the warmer, and she gets all cozy and get all positioned, get her arms down to her side, and then you step back behind the image, the control panel, you make your exposure, and you have this. Anybody? If you haven't, you will. Sooner or later, it's going to happen, right? So Really, really recommend that you get the arms out from underneath the covers so that you can see them, so that as soon as you rotor up, they, you know, get them out so that you can look and watch while you make your exposure. All right. So what we're going to look for is centering. We'll talk about pathology, body habitus. Take a look at some images there. Usually, your technique correction is going to be mass, again, because KVP, increased percentage of scatter radiation reduces contrast, which it doesn't anymore. So again, I think we're going to see a change in KVP eventually. So usually our mass is going to be a 30 to 50% change, or snatch, as it were. There we go. Or a 5 to 8% change in KVP. All right, so image analysis, we want to make sure we get the anatomy. We want to make sure that we look for positioning errors. There we go. Positioning errors, we're going to look for motion, we're going to look for rotation, specifically in positioning errors. We're going to look at the ribs, the pelvis. In the pelvis, we're going to look at the iliac wings, and we're also going to look at the sacrum in its position. And then again, if we have a patient with scoliosis, you're not going to get complete lack of rotation in that patient. Just not going to happen. All right, so pathologies, we're going to look for free air. We're going to look for air fluid levels, which indicate the patient has bowel obstruction. We're going to look for, not really look for, but we're going to question the possibility of edema, because it's going to affect our technique. But whenever we're using automatic exposure, you know, your technique correction should be taken care of. If you need to increase image receptor exposure, there are ways to do that, but you can do that just with the positive and negative density settings, or you can change selection of your photocell orientation. All right, so things also that we're going to look for: feeding tubes. Are they in the right place? Are they in the lung? Are they far enough into the digestive system? Neonatal central lines and neonates. Most of the time what they're going to do is they've got access to a central line as soon as they cut the umbilical cord. So most of the time what they're going to do, and I've never seen anything aside from this, is they'll use the umbilical vein as central line. So that's what you call a UVC, a umbilical venous catheter, or via catheter. So we've got feeding tubes, NG tubes, duodenal tubes, are the different types of tubes we're going to look at. So it's your basic positioning, L4, L5 at the iliac crest. Make sure that you get the inferior border of the symphysis pubis. Can't stress enough, recommend you not palpate for the symphysis pubis. You know, if you do, that's entirely up to you, but I'm just telling you, I don't recommend it. Upright, the textbook says 2 inches above the iliac crest, but I'm telling you, it's much more difficult to find the iliac crest with patients standing upright. So really what I recommend that you do is just put the top of the image receptor at the axilla, which seems like it's awfully high, because you look at this guy and the axilla is way up here, but you know, consider that you've got some soft tissue that's going to push it down to about there, which is going to put the center of your image receptor right about here, which is the same positioning. Much easier just to put the top of the image receptor at the level of the axilla. You don't have to go poking around on the patient. So what we want to see is from the symphysis pubis, which is not on here, all the way up to as much of the abdomen as possible. The reason that the radiologists want inspiration now is just push more of the contents of the abdomen down onto the image, which is fine. Again, they're paying for their malpractice insurance, and if that's what they're asking for, then go for it, right? So, but you do need to see the symphysis pubis. All right, so motion artifact, we got the textbook, you know, talks about the motion artifact and which is voluntary and which is involuntary. And it says, well, you can't really see the ribs on this one, so we're going to call this voluntary as opposed to you can see the ribs. They're not blurred on that one, so it's involuntary motion. You know, if you look over here, you can see that rib pretty sharply. So motion is motion, right? Regardless of whether it's involuntary or voluntary motion, motion is motion. So short exposure times, good instructions for the patient, and if you still have motion with both of those things, you just can't get rid of it. If you have a patient who's got a Parkinson's, anybody have a Parkinson's patient? They shake, they can't help it. You can have them hold on to the side of the bed, and that might help, or if they're upright, hold on to the wall bucky, and that might help. But there's a pretty good chance you're going to have motion on a Parkinson's patient. So how about this one? Is this good? Can't see the symphysis pubis, right? So this is a KUB. We see supine here. Can't see the symphysis pubis. Would you repeat this?
Yeah, what tech am I with?
What's that?
What tech am I with?
What tech are you with? So it takes, just send it. It doesn't matter what it looks like. Yeah, that's what I'm hoping you don't become. Okay. We got enough of those. We don't need any more of those. What's that? Jenna?
No, she was.
Oh.
What, you just do a bladder?
Bingo, bingo. Just do a bladder shot. You know, this is a young patient. You can kind of see where, you know, you've got some plates that aren't completely sealed up here, right? So this is a young patient. You certainly would not want to go back in and reshoot the entire KUB. If you need to make sure that you include the symphysis pubis, just do a bladder shot. Just do a bladder shot. You know, top of the image receptor at the ASIS, or top of the collimated field, since you're using one image receptor size, top of the collimated field at the ASIS, and just do a bladder shot. All right, so what do we have here?
Rotation.
We have rotation. So a lot of things that we can look at for rotation. One is we can look at the ribs. The ribs on the side that you're rotated towards are going to appear more elongated because they become more parallel to the image receptor. The ones on the elevated side are going to look more scrunched up. We look at the pelvis, and in the pelvis we can look at a lot of different stuff. We can look at the obturator foramen, the one on the side closest to the image receptor where we're rotated towards. It'll be scrunched, and the open one is going to be side elevated. We can see the pretty good SI joint here, right? The iliac wing on the side closest to the image receptor is going to be flattened out, and the one on the elevated side is going to be more vertical. You can also look at the position of the sacrum within the birth canal here, essentially, what would be the birth canal. So it's going to tilt towards the elevated side. So we've got a lot of stuff we can look at. We're getting to the point where we can see Scotty dogs on this one. So we've got some pretty decent rotation here. I wouldn't hand that in. All right, so this is a train wreck, really. We've got a lot of stuff wrong on this one. We've got rotation, serious rotation. We got tilt. We've got you know, part of this is just completely flipped.
But can they see
What's that?
But can they see what they're looking for?
Bingo, bingo. So what do you see here?
Tip.
That's on the
That's a
left.
tip, right? So did you go up to the room and did you shoot this for a feeding tube placement? And if you did, this looks like it's probably a duodenal tube, like a Dobhoff or something like that. That's not where they want it. Where do they want it? In the duodenum. So your saving grace on this is they're going to advance that and they're going to call you again to shoot a second one to see if it's in the duodenum. Just stick around and shoot it again, right? Because they're going to want another one anyway, and that's the one you hand in. This is a burner in that case, right? So can you see what you need to see? Did you go up to see whether or not, you know, the feeding tube was in the right place? Can you see that? Yeah, yeah. So even though this is just, plus this is a young patient too. See the epiphyseal plates? Can I go blast that patient a second time?
That's probably the best.
Once they adjust it.
Once they adjust it, right? So I think what we've got here is a UVC catheter, possibly. I don't know that for sure. This is also a little bit of a train wreck. We don't have bladder. We've got too much lung. But if that's what we're looking for, and most of the time it's going to go from here up into the, into the vena cava. So, would you repeat that? Well, chances are, if you're shooting for a UVC placement, the doctor's standing right there. Do you need another one?
No.
And if he or she says no, then you're golden, right? But would you do this better the next time?
Yes.
Yes, yeah, better. So upright abdomen, basic positioning is really the same with the exception of potentially putting the top of the image receptor in the armpit. Right? Except for, well, it doesn't really matter anymore because the doctor's not there anymore, but some doctors like to see the symphysis pubis and the entire bladder area on the upright abdomen. And the reason for that is because what do we normally shoot upright abdomen for? Two things: air fluid levels and free air, right? So where's the free air gonna situate? Under the diaphragms, right? Because all your abdomen's all water, right? So it's gonna go up and everything else is gonna go down. So chances are, if you're doing an upright abdomen, you probably did at least a one-view chest x-ray on the patient as well. And you can see where the free air is. So on chest x-ray, back in the days of screens and films, you could see it easier on a chest x-ray than what you could on an upright abdomen. So some of your doctors say, nah, I want to see the bladder on the upright abdomen. Give them what they want. That's their protocol, their routine. You kind of see a routine here, right? Give the doctor what they want. So follow doctor's protocol. Positioning is pretty much the same, except for now everything is vertical as opposed to horizontal. So your coronal plane is going to be vertical. Your sagittal plane now is going to be vertical. Perpendicularity and parallel is going to be the same. So weight, evenly distributed, shoulders equidistant from the image receptor, having the patient not rotated. Make sure the ASIS is equidistant from the image receptor and separate the arms just a little bit, right? Generally, you don't have a problem with the hands over the stomach upright as what you did with the patient in KUB. All right, so anatomy included, we just talked about that, maybe radiology specific. Rotation is the same, but if we're shooting our upright to include the diaphragms, then you might not be able to use the position of the sacrum inside of the pelvis. So looks like that. So upright abdomen, we're looking for bowel patterns. We're looking for air fluid levels to indicate whether or not we've got a bowel obstruction. So we've got, everything is the same. The appearance of the pelvis is going to take on a different look with the patient upright. So the iliac crests, for the most part, are not going to be as rounded. They almost look like a shot patient P8 in a P8 projection. So upright abdomen. We got a little bit of rotation on this one, not significant. So good upright abdomen. Again, we've got a young patient. We've got open epiphyseal plates all over the place on this one. Yeah, I can't see the diaphragm, so depending on what, doctor's protocol, it could be good, could be bad, except for you got a little bit too much of the symphysis pubis. I probably, on the next time I shot a x-ray on this patient, I'd probably collimate down a little bit more to get rid of some of that. And we do see evidence of air fluid levels, so probably as good as, I wouldn't go back and collimate this and shoot this patient again just to get rid of some of that, right? That'd be counterproductive. So just do better next time. Right, so what we're going to look for is ascites, bowel obstruction, small bowel obstruction, large bowel obstruction, evidence of megacolon, and I just threw that in there. She's not even here. She was asking about megacolon the other day, and then we're going to look for free air as well. So I didn't really have a good ascites image, so we're going to look at some things that kind of look like ascites. So you go up to the patient's room, you're doing a portable x-ray on a patient, you walk into the patient's room, and you see a patient that looks quite large. The problem that you're going to run into with that patient is what's causing the patient to be large, right? Are they obese? Are they not necessarily obese, but they're full of water, ascites, or do they have bowel obstruction? And two of those, your technique can kind of parallel each other, but if you're looking at a patient with a big distended stomach and you think the patient's got ascites, and you set a technique for that, and it turns out that patient has bowel obstruction, then you're going to overexpose the patient, overexpose the image receptor, right? So you need to find out what's going on with the patient, or telltale signs of what that thing is, right? So you walk into the patient's room, they get this big distended stomach, they've got an NG tube in, and it's hooked up to a suction canister, and suction canister has bile inside the canister. That is a good indication the patient has bowel obstruction, okay? First off, maybe ask the nurse, look at the chart, find out, read your request, see what it is that you're shooting the thing for. But if all of that fails, that's your telltale indicator the patient's got bowel obstruction. Also, look at the patient. If the patient has a mask on, I don't mean a COVID mask, but like a respirator, that strap that's going across their face, if that's just kind of mashed into them, that's a good indication the patient's full of water, because you just don't get water just on the stomach, you get water everywhere. Look at their ankles. Most people, you can see the malleoli on their ankles, no matter how big they are, you can still see evidence, right? But some people just have cankles, right? And look for it, and then touch the patient. And if you squeeze on their ankles, and I don't mean squeeze hard, but squeeze on their ankles just a little bit. And if it's like memory foam and it doesn't bounce right back, that patient is full of water. If it does bounce back, then that patient's probably full of gas, right? Or maybe they just got a beer belly. I don't know. So, bless you. So, what that's going to give us is, because of the amount of water that you're going to be shooting through, it's going to reduce your contrast. Your overall appearance of your image is going to come out kind of foggy looking, much like what you would see with a hypersthenic patient. That's what we're looking at here. This patient does not have ascites. That's just that's a belly roll. Okay, so it's a hypersthenic patient. Sometimes too, we can have a patient who's lost so much bone mineralization that it also kind of takes on the appearance of ascites, and that's what we have here. Morgan, this was your image. So what we've got here is bone mineralization is lost, and we lose that contrast, right? And it kind of gives the same appearance. I don't know.
I didn't take the picture.
You didn't take it? Okay. So, I can't tell for sure, but just looking at look at the ribs. The ribs and soft tissue, really, there's not a whole lot of density difference. There's not a lot of contrast there, right? So, would indicate to me that this patient's got some advanced osteoporosis. So, we got that. So, small bowel obstruction, that wasn't even written wrong. It just came out of my head. So small bowel obstruction, we've got two different types. One is a true obstruction, as a mechanical obstruction. The other is a non-obstruct ileus. So a true obstruction, a mechanical obstruction, is usually secondary to something else. Volvulus, intussusception, something like that. Some sort, maybe a carcinoma, apple core lesion, adenocarcinoma. The other is what we call a non-obstruct ileus, and that occurs from a lot of different things. So it could be a patient has had surgery, so medication can cause the bowels to stop, right? Pain can cause the bowels to stop. So, you know, if you've had kids, you know that, and if you've not had kids, here's your indication. You're going to have an ileus. Most likely when you go into labor, your bowels are just going to say, I don't want to do this. And you've got a non-obstruct ileus. It happens. If you don't know, they're going to give you an enema to try to get rid of some of that before you go into labor. Okay? So, educating you all the way across the board here. So, yeah, it's a fun time. I'm not going to do that, huh? So, that's non-obstruct ileus, and what we're looking for, just single loop valve here. What we're looking at is air fluid levels. So, we've got some sort of valve obstruction going on here, small valve obstruction. Most of the time, you know, you have an adult valve obstruction, that's what you're going to be looking at. Still a small valve obstruction. You see a lot of air fluid levels. This patient is, I don't see a NG tube. They're getting an NG tube. And they're getting hooked up to suction. Try to get rid of some of that. So, got that one. And then you've got large valve obstructions, so, you know, kind enough to give us a big arrow for this one, as if we couldn't see, you know, where the gas pattern ends. But we've got a large valve obstruction. If it gets bad enough, you'll start to lose those haustral markings, and you'll get what we call megacolon. So this is what we call aganglionic megacolon. Kids born with it, they've just got a portion of the valve that just doesn't work right. And they'll probably have to have surgery to correct that. This one over here is, that patient's got colitis. You get that stovepipe appearance where you lose the haustral markings, and you know that led to this person's valve obstruction megacolon. So this is not Leslie, but this is the image she she gave us. Again, we kind of have an appearance in this case of possibly some aside. We've got some loss of contrast, loss of bone mineralization. Do you remember anything specific about it?
No, I think they were just looking for kidney stones.
Kidney stones, okay. We got a kidney stone one coming up. Well, that looks like kidney stone right there. Heidi? Yeah, there's kidney stone. So, you know, that's starting it. What?
They made me repeat it.
They made you repeat it because of that right there?
Yeah, they
Yeah.
ended up doing a blindness shot.
Yeah, well, you know, that's something I think we've gotten away from. You know, back in the day, if you didn't put your marker on the image, you were going back and you were repeating the image. All right, so that might have been a little excessive.
Might.
Why?
Said might.
Might, yeah, that might be a little excessive. But you know what you learn to not forget to do? Put your marker on the image. Exactly. So kind of the same thing here. Might that have passed? Yeah, maybe it might have, but what'd you learn from it?
Go lower.
Exactly.
Don't ask that, take the
Okay.
check off.
So on the flip side of that, you know, I mean, we can see the pathology that we want to see. We can see the kidney stone there, but you know, I mean, we certainly could have been centered up on that a little bit better. A little more of the abdomen, a little less of the, you know, other stuff. Kind of same thing here. You know, what were we looking for on this one though? Where are you? There you go.
Oh, I didn't take that.
You didn't take it.
No.
Okay. Okay. Well, it looks like it's probably post CT. You know, obviously a little better center. Almost looks like a pelvis with the image receptor misoriented. But you know, we might have been looking for, you know, whatever this thing is. Okay. Oh. Hey, Kenny's not here. I wanted to. Yeah, I think she was saying
It
it.
was some kind of, it was a lead of some type.
That was eating leads or something.
EKG leads or something.
Eating the EKG leads.
Yeah.
Yeah. Was this from Rusk? You
No,
remember?
this was in Athens. I took these.
Yeah.
Oh, really? You
I
took
thought
it? Okay.
I guess we might have sent the same pictures.
Maybe.
I sent those.
Maybe. Okay. So they were eating the leads.
Yes, he was eating some type of wire.
Okay. Was it from a mental institution?
It
Somebody-
was an inmate.
It was an inmate. Okay. Okay, so the reason I asked that is because Jackson, and I didn't know if there was anything out towards Athens as far as, you know,
There's something.
Nut Hut, but Rusk, we used to have patients all the time come up from Rusk eating the batteries out of the Walkman. Okay, you don't really know what a Walkman is, but before iPods and before iPhones, we had these things that we'd carry around, a CD or a cassette. You don't know what that is either. But a cassette, you'd play it, and it took 4 to 6 AA batteries. And a patient would just swallow those things just to get out of the hospital.
Yeah, they all come to Jacksonville.
Was that?
They all come to Jacksonville.
Oh yeah, they all would all go to Jacksonville.
They should.
So, you know, patients from mental institutions, they'll do some wild things to get out. You know, also people from just prison system will too, just to get out for a day. You know, I don't know about somebody from, you know, a mental institution. I probably wouldn't strike up a conversation with them, but and they you know, they say don't talk to your patients if they're from prison systems. I love to talk to people from the prison system. And, ever see Shawshank Redemption? Everybody, yes? Okay. No guilty man in Shawshank. You'll never have a prisoner say, yeah, I did this. Ever. I ain't do nothing, man. They framed me. I didn't do anything. But they'll tell you what they're accused of. You know, they're proud of that. But,
I always get mad at the security with them.
oh, yeah?
Yeah, like
They're just
one of the
rude.
last ones I did in Jacksonville, like bring him in a wheelchair, go to help him get on the table. I'm like, no, I'm like, is this all urine? The cop's like, yeah.
Oh, no.
I was like, you're not gonna effing tell me, you piece of
Oh, no.
yeah. Just
Oh.
covered completely head to toe.
Yeah, you don't touch them. You just
Oh,
Well,
that's just
I'm not mad at the inmate. I'm mad at the cop being like, yeah, I know he pissed himself. I'm not gonna tell you.
Yeah. Exactly. Okay. So again, she's not here to tell us what's going on here. Bladder shot. Or does anybody know anything about this one? No.
Is that you?
Who's?
Jeremy's market, I think.
Jeremy's market.
I don't know nothing.
The market just says R. Oh, there it is. Okay.
My middle name's Dan.
So did you have any information on this?
I don't recollect these.
Somebody just stole your marker and took this extra. Oh yeah. I hate when that happens. So aside from bladder, it looks, and possibly getting this lead out of the way, it looks pretty good. So yeah, did you ever find out what these were?
They never said it, and even in his records, they never said what it was. I still don't think it was. They claimed it was pomegranate seeds, but I don't think it was pomegranate seeds. The kid was autistic. He ended up just passing it through. They filled it up with gastro and then kind of did like a therapeutic enema,
Mm-hmm.
and he ended up passing, I think, most of it. So
Yeah.
he didn't need surgery. But one of the guesses was Orbeez.
Yeah.
There's no telling.
Yeah, that's what I asked.
Just because like it soaked up the contrast and how it's so
What is it?
opaque, and then each one of them are perfect circles. So
So it's an Orby is.
Orbeez are those things that soak up the water, and then but they're perfectly shaped.
Mhm.
Like each one of those are perfectly shaped.
They have like a texture like Jello.
Okay. Yeah.
But they're like poisonous. I thought that was funny. Yeah.
Poisonous?
I'm pretty sure they are. Yeah, you're not supposed to like. They say that like kids want to eat them because they look.
Huh.
I mean, if it absorbs anything, yeah, you don't want that in your system.
Yeah, right.
You don't want to put cat litter in your intestines.
Yeah.
Yeah.
So then
Dry
It could be
out.
bad.
Yeah.
Yeah. So, yeah, I don't know what it is, but kids will eat anything. And probably one of the most dangerous things kids can eat are magnets. You know, they've got all those toys with little magnets in them.
Oh,
And, you gotta watch your kids close whenever they're little enough that they'll pop everything in their mouth. But magnets don't seem all that big a deal. And swallowing a magnet is not a problem, but swallowing 2 magnets is, because
Everywhere.
if let's say one goes through the C loop of the duodenum, and the other one just makes it to the pylorus, and they together, they ain't going anywhere, not until they have surgery, right? So if it's in there long enough, then it becomes gangrenous, and now they're looking at losing a portion of their bowel. So again, you know, just loss of bone mineralization in this patient, just a mess. And Sylvia gave us this one, and there's your kidney stone. Staghorn kidney stones just completely fill up the calyces. And the treatment for this, they can't do an S-wall. They can't do shockwave lithotripsy and break that up. What they're going to have to do is go in and retrieve it, and what they'll do is they'll punch a hole in the patient's back and in their kidney about the size of your thumb, and they'll go in there with it sounds like a grinder, but it's some sort of sound wave breaker upper device. They'll stick it in there and grind it up, and then, you know, try to wash it out. So yeah, it's ugly. And Sydney, do you have anything on this one? No. You're gonna have to take notes. So again, bladder shot,
I
maybe.
didn't submit that image, I mean.
What's that?
I didn't submit that to you, so.
It had your marker on it though. But again, you know, we look at see the lung markings down here, posterior portion of the. So decubitus, just a couple of things about decubitus, and we'll be done. Managed to get through that in about an hour, maybe a little bit more. So decubitus, remember we do a decubitus if we're doing, if the patient can't get upright, right? And where we shot a decubitus chest x-ray, and it depended on the pathology, which side we'll put down, fluid downside, air upside. On an abdomen, let's say we're doing a contrast study, air contrast PE, then we're always going to do left side down, and that's to put the gastric bubble down. This is something I've never fully understood, is that if you're doing any kind of an exam, be it an upright or a decubitus for free air, you really should put the patient into that position for a few minutes to enable that air to rise, right? So to include the diaphragm on an upright abdomen makes perfect sense. You know, if you're looking for free air, right? Include the diaphragm because that's where it's going to settle. It never really made it a whole lot of sense to me for a routine decubitus for free air to include the diaphragm on the decubitus, because where's the air going to settle? The right-hand side, right? Not necessarily under the diaphragm. So I never really fully understood that, except for possibly to make sure that you include the entire abdominal cavity, you know, and if you didn't include the diaphragms and the free air was just below the right diaphragm, then potentially, you know, you can miss it. So rotation is going to be the same. Structure shown going to be dependent on whether you shoot with the diaphragm included or if you shoot more like KUB. Yeah.
Quick question, how long should they be in that position?
Some texts will say 15 minutes. So that might be a little excessive, you know. If you've got the time, yeah, 15 minutes is probably pretty good. If you don't, then it's probably going to be there in 10, maybe less than that. So a few minutes, you know.
What does Merrill say?
What's that?
What does Merrill say?
Merrill says 15. I'm pretty sure 15. So this is what we're looking at. So spine's process in the middle of the spine. We don't really see any kind of rotation there. It looks like it could. So air fluid levels, just like an upright, free air under the diaphragm, which is shown, I think, on the next one right here. So again, repeat that because of the bra. Probably not. Probably not, unless you've got a radiologist or the tech that you're working with is a real stickler. This is the bony structure looks like this is a fairly young woman, so you really wouldn't want to go back and repeat this and blast her a second time, but you can see the free air pretty well. So, any questions?